All right, future nurses, welcome back to Stancoast NCLEX Preparation Series. Today we are solving 50 high-yield NCLEX style questions designed to sharpen your clinical judgment, strengthen your prioritization skills, and boost your confidence before exam day. Remember, NCLEX is not about memorization. It is about thinking like a safe and competent registered nurse. As we go through each question, pause the video, attempt it yourself, eliminate the wrong options, and then compare your reasoning with the explanation. That is how you truly prepare. These questions will cover medical surgical nursing, pediatric nursing, pharmacology, prioritization, and safety, the most tested areas on the exam. Stay focused, think critically, and use every rationale as a learning opportunity. If you are ready to challenge yourself and level up your preparation, let us begin with question 1. Now let us start with a high-priority endocrine emergency scenario. In question 1, a client with type 1 diabetes is found unconscious in bed with a glucometer reading of 38 milligrams per deciliter and no intravenous access available. The question asks what the nurse's priority action should be. Here are the options. A. Administer intravenous dextrose. B. Give 15 grams oral glucose. C. Administer intramuscular glucagon. D. Start normal saline infusion. The correct answer is C. Administer intramuscular glucagon. Since this client has severe hypoglycemia and is unconscious, oral glucose is contraindicated due to the risk of aspiration. In addition, there is no intravenous access, so intravenous dextrose cannot be administered immediately. Therefore, intramuscular glucagon becomes the fastest and safest intervention because it stimulates the liver to convert glycogen into glucose. Most importantly, restoring blood glucose rapidly is critical to prevent irreversible brain injury. Moving forward to a cardiovascular emergency, question 2 presents a client with acute ST elevation myocardial infarction arriving in the emergency department. The nurse must determine which medication to administer first if no contraindications exist. The options are A. Morphine, B. Nitroglycerin, C. Aspirin, D. Metoprolol. The correct answer is C. Aspirin. Aspirin works by inhibiting platelet aggregation and preventing further clot formation in the coronary arteries. It significantly reduces mortality when administered early in myocardial infarction, while nitroglycerin and morphine relieve pain and decrease workload on the heart. They do not directly prevent clot expansion the way aspirin does. Therefore, aspirin is the immediate life-saving priority. Next, let us analyze a respiratory complication. In question 3, a client with chronic obstructive pulmonary disease receiving 6 liters per minute of oxygen via nasal cannula becomes drowsy and confused. The options include A. Hypoglycemia, B. Carbon dioxide retention, C. Oxygen toxicity, D. Pulmonary embolism. The correct answer is B. Carbon dioxide retention. Clients with chronic obstructive pulmonary disease often rely on hypoxic drive to stimulate breathing. When given excessive oxygen, their respiratory drive can become suppressed, leading to carbon dioxide retention, also known as hypercapnia. Elevated carbon dioxide levels cause drowsiness and confusion, a condition commonly referred to as carbon dioxide narcosis. Shifting to electrolyte interpretation in question 4, a client's electrocardiogram shows tall peaked T waves and widening QRS complexes. The options are A. Hypokalemia, B. Hyperkalemia, C. Hypercalcemia, D. Hyponatremia. The correct answer is B. Hyperkalemia. Hyperkalemia significantly alters cardiac conduction and characteristically produces tall peaked T waves and widened QRS complexes. If untreated, severe hyperkalemia can progress to ventricular arrhythmias and cardiac arrest, making this a life-threatening electrolyte imbalance that requires immediate action. Now let us focus on neurological management. In question 5, a client with increased intracranial pressure after head trauma requires proper positioning. The options include A. Supine with pillow under head, B. Head of bed elevated 30 degrees, C. Trendelenburg position, D. Prone position. The correct answer is B. Head of bed elevated 30 degrees. Elevating the head promotes venous drainage from the brain and helps reduce intracranial pressure. In contrast, Flat or Trendelenburg positions increase intracranial pressure by impairing venous return and should be avoided. Now, before we move to the next question, I want to quickly share something important with you. If you are truly serious about passing the NCLEX, and especially if your exam date is getting closer, then having a structured plan becomes absolutely essential, because without structure, even hard work can feel confusing and scattered. That is exactly why we created our complete NCLEX structured program. Instead of random videos or unorganized practice, this course gives you a clear step-by-step roadmap. So rather than waking up every day wondering what to study, you simply follow the system and move forward with clarity. Over time, more than 100,000 students have prepared using this system, and most of them passed on their first attempt, not because of luck, but because they followed a structured strategy. Now, if you have limited time, then we have also designed a 30-day NCLEX crash course. And this crash course is specifically built for students who need focused, high-yield preparation in a short period. It removes unnecessary content and concentrates only on what truly matters for the exam. Inside the course, you will get recorded concept-based lectures, more than 5,000 NCLEX and NGN practice questions, high-yield ebook notes, and detailed training for priority, delegation, and NGN case-style questions. So everything is organized in one place, and you simply follow the plan step by step. However, there is something very important you should know. We offer this 70% discount only on limited seats each month. And once those discounted seats are filled, the offer automatically closes. After that, the opportunity to enroll at this discounted price is gone. So instead of rushing, I would recommend this. First, watch the free demo available on our website. That way, you can see the teaching quality, the structure, and the content yourself. And then, if you genuinely feel it is the right fit for you, you can confidently enroll. You can find the website link in the description and in the bio, or simply search on Google, StanCoast NCLEX Coaching. All right, now let's move to the next question. Continuing with a critical burn scenario in question 6, a patient arrives 4 hours after sustaining 45% total body surface area burns. The nurse must identify the highest priority during the first 24 hours. The options are A, prevent infection, B, manage pain, C, maintain airway and fluid balance, D, start high-protein diet. The correct answer is C, maintain airway and fluid balance. During the first 24 hours, massive capillary leakage leads to hypovolemia and potential airway edema. Therefore, airway protection and aggressive fluid resuscitation using formulas such as the Parkland formula are essential to prevent hypovolemic shock and respiratory compromise. Let us now consider medication toxicity in question 7. A client taking digoxin reports nausea and blurred vision with yellow halos. The options include A, administer next dose with food, B, hold the medication and notify the provider, C, encourage potassium restriction, D, increase fluid intake. The correct answer is B, hold the medication and notify the provider. Yellow halos and gastrointestinal symptoms are classic signs of digoxin toxicity. The medication must be held immediately because continued administration could precipitate life-threatening cardiac arrhythmias. Transitioning into acid-base interpretation in question 8, a client with diabetic ketoacidosis has arterial blood gas results showing pH 7.25, bicarbonate 14 milliequivalents per liter, and partial pressure of carbon dioxide 30 millimeters of mercury. The options are A, respiratory acidosis, B, metabolic acidosis with respiratory compensation, C, metabolic alkalosis, D, respiratory alkalosis. The correct answer is B, metabolic acidosis with respiratory compensation. The low pH and low bicarbonate confirm metabolic acidosis. The decreased carbon dioxide level indicates respiratory compensation through Kussmaul respirations, where the body attempts to blow off carbon dioxide to correct the acidosis. This pattern is classic in diabetic ketoacidosis due to ketone accumulation. Now let us evaluate a post-operative endocrine complication. In question 9, a thyroidectomy patient develops muscle spasms and tingling around the mouth. The options include A, hyperkalemia, B, hypocalcemia, C, hypernatremia, D, hyperglycemia. The correct answer is B, hypocalcemia. Damage or accidental removal of the parathyroid glands during surgery can cause hypocalcemia. Early signs include perioral tingling and muscle spasms, and if severe, this can progress to tetany and even laryngospasm, which is a medical emergency. Moving into anticoagulation management in question 10, a client receiving heparin develops bleeding gums and hematuria. The options are A, vitamin K, B, protamine sulfate, C, fresh frozen plasma, D, tranexamic acid. The correct answer is B, protamine sulfate. Protamine sulfate is the specific antidote for heparin and works by binding to heparin and neutralizing its anticoagulant effect, thereby reducing bleeding risk. Now, before we move to the next question, I want to quickly share something important with you. If you are truly serious about passing the NCLEX, and especially if your exam date is getting closer, then having a structured plan becomes absolutely essential, because without structure, even hard work can feel confusing and scattered. That is exactly why we created our complete NCLEX structured program. Instead of random videos or unorganized practice, this course gives you a clear step-by-step roadmap. So rather than waking up every day wondering what to study, you simply follow the system and move forward with clarity. Over time, more than 100,000 students have prepared using this system, and most of them passed on their first attempt, not because of luck, but because they followed a structured strategy. Now, if you have limited time, then we have also designed a 30-day NCLEX crash course. And this crash course is specifically built for students who need focused, high-yield preparation in a short period. It removes unnecessary content and concentrates only on what truly matters for the exam. Inside the course, you will get recorded concept-based lectures, more than 5,000 NCLEX and NGN practice questions, high-yield ebook notes, and detailed training for priority, delegation, and NGN case-style questions. So everything is organized in one place, and you simply follow the plan step by step. However, there is something very important you should know. We offer this 70% discount only on limited seats each month, and once those discounted seats are filled, the offer automatically closes. After that, the opportunity to enroll at this discounted price is gone. So instead of rushing, I would recommend this. First, watch the free demo available on our website. That way, you can see the teaching quality, the structure, and the content yourself. And then, if you genuinely feel it is the right fit for you, you can confidently enroll. You can find the website link in the description and in the bio, or simply search on Google StanCoast NCLEX Coaching. All right, now let's move to the next question. Next, in question 11, a client with hypovolemic shock secondary to hemorrhage is assessed in the early compensatory stage. The options include A, hypotension, B, bradycardia, C, tachycardia, D, decreased respiratory rate. The correct answer is C, tachycardia. During the early compensatory stage, the sympathetic nervous system is activated to maintain cardiac output. This leads to tachycardia and vasoconstriction in an attempt to preserve blood pressure. Hypotension is a late finding, and respiratory rate typically increases rather than decreases. Continuing with postoperative monitoring in question 12, a patient has a urine output of 20 milliliters per hour for the past 3 hours. The options are A, normal finding, B, early sign of renal hypoperfusion, C, bladder distension, D, side effect of anesthesia. The correct answer is B, early sign of renal hypoperfusion. Adults should produce at least 30 milliliters per hour. Sustained oliguria suggests decreased renal perfusion, often due to hypovolemia or early shock, making this a critical early warning sign. In question 13, a client taking warfarin has an international normalized ratio of 5.2 without active bleeding. The options include A, administer heparin, B, hold the warfarin dose, C, increase warfarin dose, D, give protamine sulfate. The correct answer is B, hold the warfarin dose. The therapeutic range is typically 2 to 3. An international normalized ratio of 5.2 indicates increased bleeding risk. Without active bleeding, the priority is to hold the medication and notify the provider. Protamine sulfate reverses heparin, not warfarin. Now consider early post-operative complications in question 14. A client becomes restless and anxious 30 minutes after surgery with oxygen saturation of 90% on room air. The options are A, pain reaction, B, early hypoxia, C, anxiety disorder, D, hyperglycemia. The correct answer is B, early hypoxia. Restlessness and anxiety are classic early signs of hypoxia. Cyanosis is a late finding. Post-operative patients are especially vulnerable due to anesthesia effects and decreased respiratory effort. Finally, in question 15, a nurse must confirm placement of a nasogastric tube before feeding. The options include A, injecting air and auscultating, B, checking aspirate color, C, measuring tube length, D, X-ray confirmation. The correct answer is D, X-ray confirmation. X-ray is the gold standard for confirming nasogastric tube placement. Air auscultation is unreliable and may lead to aspiration if feeding begins incorrectly. While aspirate characteristics can provide clues, they are not definitive. Therefore, radiographic confirmation ensures patient safety before initiating feeding. In question 16, a client with left-sided heart failure reports shortness of breath, and you are asked which assessment finding correlates most strongly with this condition. Here are the options. A, jugular vein distension, B, peripheral edema, C, pulmonary crackles, D, hepatomegaly. The correct answer is C, pulmonary crackles. In left-sided heart failure, the left ventricle fails to effectively pump blood forward, causing blood to back up into the pulmonary circulation. This increased pressure leads to pulmonary edema, which manifests as crackles upon auscultation. Although jugular vein distension, peripheral edema, and hepatomegaly are important findings, they are more characteristic of right-sided heart failure. Therefore, when you hear shortness of breath combined with crackles, immediately think pulmonary congestion from left-sided failure. Moving forward to a life-threatening allergic reaction in question 17. A patient suddenly develops wheezing, hypotension, and facial swelling after receiving an antibiotic. The options include A, administer antihistamines, B, start intravenous fluids, C, administer epinephrine, D, place patient in Trendelenburg position. The correct answer is C, administer epinephrine. This presentation is classic for anaphylaxis, a severe systemic hypersensitivity reaction. Epinephrine is the first-line treatment because it causes bronchodilation to open the airways, vasoconstriction to increase blood pressure, and stabilization of mast cells to reduce further mediator release. Although antihistamines and intravenous fluids are supportive treatments, delaying epinephrine administration significantly increases mortality. In anaphylaxis, epinephrine always comes first. Next, let us consider infection control in question 18. A patient diagnosed with active pulmonary tuberculosis must be placed under which isolation precaution? The options are A, contact precautions, B, droplet precautions, C, airborne precautions, D, protective isolation. The correct answer is C, airborne precautions. Tuberculosis spreads through airborne droplet nuclei that remain suspended in the air for prolonged periods. Therefore, patients must be placed in a negative pressure room and healthcare workers must wear N95 respirators. Contact and droplet precautions are insufficient because tuberculosis particles are much smaller and remain airborne longer than typical droplets. Now let us shift into electrolyte interpretation in question 19. A client with hypokalemia has a potassium level of 2.8 milliequivalents per liter. Which electrocardiogram change should the nurse expect? The options include A, peaked T waves, B, U waves, C, ST elevation, D, wide QRS complex. The correct answer is B, U waves. Hypokalemia delays ventricular repolarization, leading to characteristic U waves and flattened T waves on the electrocardiogram. Severe hypokalemia increases the risk for dangerous arrhythmias. It is important to remember that peaked T waves are associated with hyperkalemia, not hypokalemia. Therefore, whenever potassium is low, think U waves. Finally, in question 20, a client presents with severe epigastric pain radiating to the back and elevated serum amylase levels. The options are A, cholecystitis, B, gastritis, C, pancreatitis, D, peptic ulcer disease. The correct answer is C, pancreatitis. Acute pancreatitis classically presents with severe epigastric pain that radiates to the back and is often associated with elevated amylase and lipase levels. Common causes include alcohol use and gallstones. Interestingly, patients frequently report that the pain improves when leaning forward, which reduces pressure on the inflamed pancreas. This combination of severe back-radiating pain and elevated pancreatic enzymes should immediately trigger suspicion for pancreatitis. Beginning with question 21, a client with open-angle glaucoma is prescribed timolol eye drops, and the nurse must determine the most important assessment before administration. The options are A, respiratory rate, B, blood glucose level, C, apical heart rate, D, visual acuity. The correct answer is C, apical heart rate. Timolol is a non-selective beta blocker, and even though it is administered as an ophthalmic preparation, it can be systemically absorbed. Because of its beta-blocking properties, it can cause bradycardia and hypotension. Therefore, assessing the apical pulse prior to administration is essential for patient safety. Although visual acuity is relevant to the disease process, it is not the immediate safety priority before giving the medication. Now transitioning into adrenal disorders in question 22, a client with Cushing's syndrome is admitted for evaluation. Which assessment finding reflects excess cortisol? The options include A, hyperpigmentation, B, moon face and truncal obesity, C, severe hypotension, D, weight loss. The correct answer is B, moon face and truncal obesity. Excess cortisol leads to fat redistribution, resulting in characteristic features such as moon face, buffalo hump, and central or truncal obesity. Additionally, cortisol excess causes hypertension, hyperglycemia, and muscle wasting. Hyperpigmentation and hypotension, on the other hand, are more commonly associated with Addison disease, where cortisol levels are deficient rather than excessive. Building on that endocrine comparison, question 23 presents a client with Addison disease who reports dizziness upon standing. The options are A, excess aldosterone, B, sodium and water retention, C, decreased cortisol and aldosterone, D, increased antidiuretic hormone secretion. The correct answer is C, decreased cortisol and aldosterone. Addison disease is characterized by adrenal insufficiency, resulting in decreased production of both cortisol and aldosterone. Reduced aldosterone leads to sodium loss and water loss, causing hypovolemia and hypotension. Consequently, when the client stands up, orthostatic hypotension occurs due to the inability to maintain adequate vascular tone and circulating volume. Now, before we move to the next question, I want to quickly share something important with you. If you are truly serious about passing the NCLEX, and especially if your exam date is getting closer, then having a structured plan becomes absolutely essential. Because without structure, even hard work can feel confusing and scattered. That is exactly why we created our complete NCLEX structured program. Instead of random videos or unorganized practice, this course gives you a clear step-by-step roadmap. So rather than waking up every day wondering what to study, you simply follow the system and move forward with clarity. Over time, more than 100,000 students have prepared using this system, and most of them passed on their first attempt, not because of luck, but because they followed a structured strategy. Now, if you have limited time, then we have also designed a 30-day NCLEX crash course. And this crash course is specifically built for students who need focused, high-yield preparation in a short period. It removes unnecessary content and concentrates only on what truly matters for the exam. Next, let us consider thyroid emergencies in question 24. A client with untreated hyperthyroidism is at risk for which life-threatening complication? The options are A, myxedema coma, B, thyroid storm, C, hypocalcemia, D, Cushing crisis. The correct answer is B, thyroid storm. Thyroid storm represents an extreme exacerbation of hyperthyroidism and is characterized by severe tachycardia, hyperthermia, hypertension, and altered mental status. It is a medical emergency requiring immediate intervention. Myxedema coma, by contrast, is associated with severe hypothyroidism, not hyperthyroidism. Continuing with thyroid function in question 25, a client with hypothyroidism presents with bradycardia, weight gain, and fatigue. Which laboratory finding supports this diagnosis? The options include A. Decreased thyroid stimulating hormone, B. Elevated thyroid stimulating hormone, C. Increased triiodothyronine and thyroxine, D. Decreased cholesterol. The correct answer is B. Elevated thyroid stimulating hormone. In primary hypothyroidism, the thyroid gland fails to produce adequate amounts of triiodothyronine and thyroxine. In response, the pituitary gland increases thyroid-stimulating hormone production in an attempt to stimulate the thyroid. Therefore, thyroid-stimulating hormone levels are elevated while thyroid hormones are low. Now shifting into acute trauma management in question 26, a trauma patient suddenly develops severe dyspnea and absent breath sounds on the right side, and blood pressure begins to drop. The options are A. Simple pneumothorax, B. Tension pneumothorax, C. Pulmonary embolism, D. Atelectasis. The correct answer is B. Tension pneumothorax. In this condition, air accumulates under pressure in the pleural space, compressing the affected lung and shifting the mediastinum. This impairs venous return to the heart, leading to hypotension and severe respiratory distress. Tension pneumothorax is a life-threatening emergency requiring immediate needle decompression. Finally, in question 27, a patient with suspected acute ischemic stroke arrives within 1 hour of symptom onset. The nurse must identify the priority diagnostic test. The options include A. Magnetic resonance imaging, B. Electroencephalogram, C. Computed tomography scan of the head, D. Lumbar puncture. The correct answer is C. Computed tomography scan of the head. A non-contrast computed tomography scan is performed immediately to differentiate ischemic stroke from hemorrhagic stroke. This distinction is critical because thrombolytic therapy cannot be administered if bleeding is present. Rapid imaging ensures timely treatment within the therapeutic window and improves patient outcomes. Beginning with question 28, during a tonic-clonic seizure, which action by the nurse is appropriate? The options are A. Insert an oral airway, B. Restrain extremities, C. Turn the client to the side, D. Provide oral fluids. The correct answer is C. Turn the client to the side. During an active seizure, the primary goal is to protect the airway and prevent injury. Turning the client to the side promotes drainage of secretions and reduces the risk of aspiration. Inserting anything into the mouth, including an oral airway, can cause trauma to the teeth or airway and is contraindicated. Likewise, restraining extremities increases the risk of musculoskeletal injury, including fractures. Oral fluids must never be given during or immediately after a seizure due to aspiration risk. Therefore, side positioning is the safest and most appropriate intervention. Now, transitioning into movement disorders in question 29, a client with Parkinson's disease is prescribed levodopa-carbidopa, and you are asked the purpose of carbidopa in this combination therapy. The options include A. Prevent peripheral breakdown of levodopa, B. Increase dopamine destruction, C. Reduce blood pressure, D. Enhance serotonin release. The correct answer is A. Prevent peripheral breakdown of levodopa. Levodopa is converted into dopamine to help replenish deficient dopamine levels in the brain. However, if converted in the peripheral circulation, it can cause significant side effects such as nausea, vomiting, and hypotension. Carbidopa inhibits this peripheral conversion, allowing more levodopa to cross the blood-brain barrier and reach the central nervous system. As a result, therapeutic effectiveness increases while peripheral adverse effects decrease. Understanding this mechanism is crucial for pharmacology questions on the NCLEX. Finally, in question 30, a client with iron deficiency anemia presents with fatigue and pallor, and you are asked which laboratory value confirms the diagnosis. The options are A. Elevated mean corpuscular volume, B. Low ferritin level, C. High hemoglobin, D. Elevated reticulocyte count. The correct answer is B. Low ferritin level. Ferritin reflects the body's iron stores, and in iron deficiency anemia, these stores are depleted, resulting in a low ferritin level. Additionally, iron deficiency anemia is classified as microcytic anemia, meaning mean corpuscular volume is low, not elevated. Hemoglobin levels are decreased rather than high. Reticulocyte counts are not initially elevated because iron is necessary for red blood cell production, and without sufficient iron, the bone marrow cannot mount an adequate response. Now, before we move to the next question, I want to quickly share something important with you. If you are truly serious about passing the NCLEX, and especially if your exam date is getting closer, then having a structured plan becomes absolutely essential. Because without structure, even hard work can feel confusing and scattered. That is exactly why we created our complete NCLEX structured program. Instead of random videos or unorganized practice, this course gives you a clear step-by-step roadmap. So rather than waking up every day wondering what to study, you simply follow the system and move forward with clarity. Over time, more than 100,000 students have prepared using this system, and most of them passed on their first attempt, not because of luck, but because they followed a structured strategy. Now, if you have limited time, then we have also designed a 30-day NCLEX crash course. And this crash course is specifically built for students who need focused, high-yield preparation in a short period. It removes unnecessary content and concentrates only on what truly matters for the exam. Inside the course, you will get recorded concept-based lectures, more than 5,000 NCLEX and NGN practice questions, high-yield ebook notes, and detailed training for priority, delegation, and NGN case-style questions. So everything is organized in one place, and you simply follow the plan step by step. However, there is something very important you should know. We offer this 70% discount only on limited seats each month, and once those discounted seats are filled, the offer automatically closes. After that, the opportunity to enroll at this discounted price is gone. So instead of rushing, I would recommend this. First, watch the free demo available on our website. That way, you can see the teaching quality, the structure, and the content yourself. And then, if you genuinely feel it is the right fit for you, you can confidently enroll. You can find the website link in the description and in the bio, or simply search on Google StanCoast NCLEX Coaching. All right, now let's move to the next question. Beginning with question 31, a child with nephrotic syndrome presents with generalized edema and frothy urine, and you are asked the primary pathophysiological cause of the edema. The options are A, sodium retention only, B, increased capillary permeability, C, loss of plasma proteins in urine, D, increased red blood cells. The correct answer is C, loss of plasma proteins in urine. Nephrotic syndrome is characterized by massive proteinuria, particularly loss of albumin. Albumin plays a crucial role in maintaining plasma oncotic pressure. When albumin levels drop significantly, plasma oncotic pressure decreases, allowing fluid to shift from the intravascular space into the interstitial tissues, resulting in generalized edema. Although sodium retention contributes to worsening edema, it is secondary to the primary issue of protein loss. Now transitioning into chronic cardiac management in question 32, a client with chronic heart failure reports a rapid weight gain of 2 kilograms in 3 days. The options include A, improved nutrition, B, fluid retention, C, muscle growth, D, medication side effect. The correct answer is B, fluid retention. In heart failure, rapid weight gain over a short period almost always indicates fluid accumulation rather than fat or muscle gain. Decreased cardiac output activates the renin-angiotensin-aldosterone system, leading to sodium and water retention. This fluid buildup worsens edema and pulmonary congestion. Therefore, sudden weight gain in heart failure is an early warning sign of decompensation. Moving to a postoperative endocrine emergency in question 33, a patient 8 hours after thyroidectomy suddenly develops stridor and difficulty breathing. The options are A, notify the surgeon, B, place the patient in high Fowler position, C, prepare for emergency airway management, D, check calcium levels. The correct answer is C, prepare for emergency airway management. Stridor indicates upper airway obstruction, often caused by postoperative hematoma or swelling compressing the trachea. Airway always takes priority over notification or laboratory evaluation. Emergency tracheostomy equipment must be readily available because rapid deterioration can occur. In life-threatening airway compromise, immediate preparation for intervention is essential. Next, in question 34, a client with bacterial meningitis is receiving intravenous antibiotics, and you are asked which finding indicates worsening condition. The options are A, mild headache, B, stiff neck, C, decreasing level of consciousness, D, low-grade fever. The correct answer is C, decreasing level of consciousness. While headache and neck stiffness are expected findings in meningitis, a declining level of consciousness suggests increasing intracranial pressure or cerebral edema. This is a life-threatening complication and signals neurological deterioration. Therefore, changes in consciousness must always be treated as an emergency. Now let us evaluate spinal cord injuries in question 35. A patient with a C5 spinal cord injury is admitted, and you must identify which complication requires the most immediate monitoring. The options include A, constipation, B, urinary retention, C, respiratory failure, D, pressure ulcers. The correct answer is C, respiratory failure. The phrenic nerve, which controls diaphragm function, originates from C3 to C5. An injury at C5 can impair diaphragmatic movement and compromise breathing. Because airway and breathing are life-sustaining functions, respiratory assessment and monitoring take absolute priority over bowel, bladder, or skin concerns. Finally, in question 36, a patient with increased intracranial pressure develops hypertension, bradycardia, and irregular respirations. The options are A, stroke improvement, B, Cushing triad, C, hypoglycemia, D, sepsis. The correct answer is B, Cushing triad. This combination of hypertension, bradycardia, and irregular respirations is a late and ominous sign of severely increased intracranial pressure and impending brain herniation. It requires immediate intervention to reduce intracranial pressure and prevent irreversible brain damage. Recognizing Cushing triad is critical because it indicates a neurological emergency. Beginning with question 37, a client with hemophilia A experiences prolonged bleeding after minor trauma, and you are asked the underlying cause. The options are A, platelet deficiency, B, vitamin K deficiency, C, factor VIII deficiency, D, excess thrombin. The correct answer is C, factor VIII deficiency. Hemophilia A is an inherited bleeding disorder caused by a deficiency of clotting factor VIII, which is essential in the intrinsic pathway of the coagulation cascade. Without adequate factor VIII, the clotting cascade cannot proceed normally, resulting in prolonged bleeding even after minor injuries. Importantly, platelet count in hemophilia A is typically normal, which helps differentiate it from platelet disorders. Therefore, this is a coagulation factor problem, not a platelet problem. Now transitioning into psychiatric medication safety in question 38, a client taking lithium reports nausea, diarrhea, and hand tremors. The options include A, normal side effects, B, early lithium toxicity, C, hypokalemia, D, anxiety attack. The correct answer is B, early lithium toxicity. Lithium has a very narrow therapeutic range, typically between 0.6 and 1.2 milliequivalents per liter. Early signs of toxicity include gastrointestinal symptoms such as nausea and diarrhea, along with fine hand tremors. If not recognized early, toxicity can progress to confusion, severe neurological impairment, seizures, and even coma. Therefore, these symptoms must be taken seriously and prompt immediate evaluation of lithium levels. Next, let us analyze electrolyte-induced cardiac instability in question 39. A patient with severe hypomagnesemia develops ventricular arrhythmias. You are asked why low magnesium causes cardiac instability. The options are A, it decreases sodium levels, B, it affects myocardial electrical conduction, C, it increases calcium excretion, D, it increases oxygen demand. The correct answer is B, it affects myocardial electrical conduction. Magnesium plays a vital role in regulating cardiac ion channels and stabilizing myocardial cell membranes. When magnesium levels are low, myocardial cells become more excitable, increasing the risk of ventricular arrhythmias, including torsades de pointes. Thus, magnesium is essential for maintaining electrical stability in the heart. Finally, in question 40, a client with an acute asthma exacerbation is using accessory muscles and cannot speak full sentences. The options are A, Oral corticosteroids. B. Long-acting beta agonist. C. Short-acting bronchodilator, albuterol. D. Leukotriene inhibitor. The correct answer is C. Short-acting bronchodilator, albuterol. In acute asthma exacerbations, rapid bronchodilation is the priority to restore airflow and relieve bronchospasm. Albuterol is a short-acting beta-2 agonist that quickly relaxes bronchial smooth muscle. While oral corticosteroids help reduce inflammation, they do not act immediately. Long-acting beta agonists and leukotriene inhibitors are maintenance medications and are not used for acute rescue situations. Therefore, immediate bronchodilation is the life-saving intervention. Now, before we move to the next question, I want to quickly share something important with you. If you are truly serious about passing the NCLEX, and especially if your exam date is getting closer, then having a structured plan becomes absolutely essential. Because without structure, even hard work can feel confusing and scattered. That is exactly why we created our complete NCLEX structured program. Instead of random videos or unorganized practice, this course gives you a clear step-by-step roadmap. So rather than waking up every day wondering what to study, you simply follow the system and move forward with clarity. Over time, more than 100,000 students have prepared using this system, and most of them passed on their first attempt, not because of luck, but because they followed a structured strategy. Now, if you have limited time, then we have also designed a 30-day NCLEX crash course. And this crash course is specifically built for students who need focused, high-yield preparation in a short period. It removes unnecessary content and concentrates only on what truly matters for the exam. Inside the course, you will get recorded concept-based lectures, more than 5,000 NCLEX and NGN practice questions, high-yield ebook notes, and detailed training for priority, delegation, and NGN case-style questions. So everything is organized in one place, and you simply follow the plan step by step. However, there is something very important you should know. We offer this 70% discount only on limited seats each month, and once those discounted seats are filled, the offer automatically closes. After that, the opportunity to enroll at this discounted price is gone. So instead of rushing, I would recommend this. First, watch the free demo available on our website. That way, you can see the teaching quality, the structure, and the content yourself. And then, if you genuinely feel it is the right fit for you, you can confidently enroll. You can find the website link in the description and in the bio, or simply search on Google StanCoast NCLEX Coaching. All right, now let's move to the next question. Beginning with question 41, a client diagnosed with ulcerative colitis reports frequent bloody diarrhea and abdominal cramping, and you are asked the primary reason for the bloody stools. The options are A, small intestinal ulceration, B, superficial inflammation of colon mucosa, C, pancreatic enzyme deficiency, D, gastric erosion. The correct answer is B, superficial inflammation of colon mucosa. Ulcerative colitis affects the colon and rectum with continuous superficial inflammation limited to the mucosal layer. The mucosa becomes ulcerated, friable, and prone to bleeding, which results in characteristic bloody diarrhea. Unlike Crohn's disease, ulcerative colitis does not involve full-thickness inflammation of the bowel wall. Therefore, the bleeding is due to fragile, inflamed colon mucosa rather than deeper tissue damage. Now, building on that gastrointestinal comparison in question 42, a client with Crohn's disease develops a fistula, and you must identify what explains this complication. The options include A, superficial mucosal damage only, B, full-thickness bowel inflammation, C, decreased immune response, D, reduced peristalsis. The correct answer is B, full-thickness bowel inflammation. Crohn's disease is characterized by transmural, or full-thickness inflammation that extends through all layers of the intestinal wall. Because the inflammation penetrates deeply, it can create abnormal connections between the intestine and other organs or structures known as fistulas. This transmural involvement is a key feature that distinguishes Crohn's disease from ulcerative colitis, which affects only the mucosal layer. Transitioning now into vascular complications in question 43, a client reports calf pain, swelling, and warmth after prolonged bed rest. The options are A, muscle strain, B, cellulitis, C. Deep vein thrombosis. D. Peripheral neuropathy. The correct answer is C. Deep vein thrombosis. Prolonged immobility promotes venous stasis, which is one component of Virchow triad. Venous stasis, endothelial injury, and hypercoagulability. Deep vein thrombosis typically presents with unilateral calf pain, swelling, warmth, and sometimes redness. The greatest danger is that part of the clot can dislodge and travel to the lungs, causing a pulmonary embolism. Therefore, this finding requires immediate evaluation and intervention. Finally, in question 44, a patient receiving intravenous heparin therapy has an activated partial thromboplastin time of 110 seconds, while the normal range is 25 to 35 seconds. The options include A. Continue infusion, B. Increase dose, C. Stop infusion temporarily, D. Administer vitamin K. The correct answer is C. Stop infusion temporarily. The therapeutic range for heparin is generally 1.5 to 2.5 times the normal value, which corresponds approximately to 60 to 80 seconds. An activated partial thromboplastin time of 110 seconds indicates excessive anticoagulation and a significantly increased risk of bleeding. Therefore, the infusion must be stopped immediately, and the provider should be notified for further instructions. Vitamin K reverses warfarin, not heparin, so it is not appropriate in this situation. Beginning with question 45, a client with syndrome of inappropriate antidiuretic hormone secretion has a sodium level of 118 milliequivalents per liter, and you are asked which symptom is most concerning. The options are A. Dry skin, B. Increased urination, C. Confusion and headache, D. Thirst. The correct answer is C. Confusion and headache. In syndrome of inappropriate antidiuretic hormone secretion, excess antidiuretic hormone causes water retention, which dilutes sodium levels and results in severe hyponatremia. When sodium drops this low, cerebral edema can develop because water shifts into brain cells. Neurological symptoms such as confusion, headache, seizures, and coma are the most dangerous findings and require immediate intervention. Therefore, neurological changes always take priority in severe hyponatremia. Moving forward to question 46, a patient with diabetes insipidus produces 8 liters of urine in 24 hours. The options include A. Excess insulin secretion, B. Deficient antidiuretic hormone activity, C. Increased aldosterone, D. Elevated cortisol. The correct answer is B. Deficient antidiuretic hormone activity. Diabetes insipidus occurs when there is either insufficient secretion of antidiuretic hormone from the posterior pituitary or renal resistance to its effects. Without antidiuretic hormone, the kidneys cannot reabsorb water in the collecting ducts, resulting in massive amounts of dilute urine. This leads to dehydration and hypernatremia if fluid intake does not match losses. Now, transitioning into emergency response protocols in question 47, during cardiopulmonary resuscitation on an adult patient with one rescuer present, what is the correct compression to ventilation ratio? The options are A. 15 to 2, B. 20 to 2, C. 30 to 2, D. Continuous compressions only. The correct answer is C. 30 to 2. According to current cardiopulmonary resuscitation guidelines, a single rescuer performing adult cardiopulmonary resuscitation delivers 30 high-quality chest compressions followed by 2 breaths. Effective compressions are essential to maintain coronary and cerebral perfusion until advanced care is available. Next, in question 48, a client with eclampsia is receiving magnesium sulfate, and you are asked which finding indicates magnesium toxicity. The options are A. Hyperreflexia, B. Respiratory rate 8 per minute, C. Hypertension, D. Seizure activity. The correct answer is B. Respiratory rate 8 per minute. Magnesium sulfate acts as a central nervous system depressant. Toxicity presents with respiratory depression, defined as fewer than 12 respirations per minute, loss of deep tendon reflexes, hypotension, and decreased urine output. A respiratory rate of 8 per minute is critically low and signals potential respiratory failure. Calcium gluconate is the antidote for magnesium toxicity and must be readily available. Continuing into respiratory mechanics in question 49, a client with chronic obstructive pulmonary disease prefers sitting upright while leaning forward with hands on knees. The options include A. Increases abdominal pressure, B. Expands lung capacity, C. Uses accessory muscles effectively, D. Reduces oxygen consumption. The correct answer is C. Uses accessory muscles effectively. This tripod position stabilizes the shoulder girdle, allowing accessory respiratory muscles such as the sternocleidomastoid and scalene muscles to assist in breathing. By maximizing the use of these muscles, ventilation improves and dyspnea decreases. This is a classic compensatory posture seen in chronic obstructive pulmonary disease patients. Finally, in question 50, a client diagnosed with myocardial infarction has elevated troponin levels, and you are asked why troponin is the most specific marker. The options are A. It rises first, B. It remains elevated longest, C. It is released only from cardiac muscle, D. It indicates muscle injury. The correct answer is C. It is released only from cardiac muscle. Troponin is highly specific to cardiac muscle cells. When myocardial injury occurs, troponin is released into the bloodstream. Although other markers such as creatine kinase, myocardial band, and myoglobin may rise, they are not as specific because they can be elevated in skeletal muscle injury as well. Therefore, troponin remains the gold standard laboratory marker for diagnosing myocardial infarction. Thank you for watching. See you soon in the next video.